So let's transition then to ER-positive disease, but now we're going to the metastatic setting because we had really interesting survival data with the CDK4/6 inhibitor palbociclib, that hit the New England Journal of Medicine, in October, coming out at ESMO. So we have our very first survival data. So Ruth, why don't you give us a feel for where are we with CDK4/6 inhibitors in ER-positive metastatic disease?
So, obviously the results are very dramatic. It's so interesting across all the trials that have been done. The hazard ratios are always about 0.55, no matter where you look at them. So I think the question really is, does everybody need them in the first line versus can some people get them in the second line? Despite very elegant work by multiple investigators, the only biomarker we have right now is estrogen receptor. I think we saw, there's an attempt in the neoadjuvant setting to use these drugs neoadjuvantly to see if you can actually find a biomarker of benefit. But again, we've come up with nothing so far. So I think for most of us, we're going to use them first line because it's very hard to ignore the kind of almost doubling of progression-free survival you're seeing for these patients. The survival data from the first-line trials, I think, will be very interesting when we see that, because if they don't have a survival advantage, then we're kind of really going to have to maybe rethink what we're doing a little bit. But again, disease control is also very important to patients, I think. So,
yeah, very impressive data. And tell us about the Paloma-3 data in the New England Journal of Medicine.
Well, so, obviously that was basically really a hormone refractory group of patients. If you look at the progression-free survival in the control arm, it was consistent with hormone refractory. And obviously, we already knew that the addition of palbociclib to fulvestrant markedly improved progression-free survival. We're now seeing a significant survival advantage, which is really very encouraging.
It was very, very interesting, getting them right there.
But you had to have prior sensitivity to hormone therapy.
Right,
what
to
does
get that
mean?
Survival advantage.
So what does that mean?
Well, they didn't define that. At least
Right.
I couldn't find it.
They kind of did. I think it was 6 months. You had to be on hormone therapy for 6 months.
6 months in the metastatic was very, very stringent. It was a primary refractory diagnosis. So no benefit from endocrine therapy in the metastatic setting. So no clinical benefit. So not more than 6 months. And neither of these could be present. If you had adjuvant endocrine therapy, you could not have been on it for 2 years. You had to recur within 2 years. So super resistant disease. So that was 20% of the Paloma-3 population. And in that population, interestingly, there wasn't any benefit from palbociclib on survival. But in those that were hormone therapy sensitive, which means just getting past 2 years of your adjuvant endocrine therapy or having 6 months on any endocrine therapy in the metastatic setting, there was this 10-month improvement in overall survival, which is really, really interesting. The overall study, the overall survival just missed statistical significance. It was, definitely, definitely in the right direction, but it just missed statistical significance. So it's really interesting what it says to us about palbociclib, in that primary endocrine therapy refractory patient population, and then also what it says to us in the more endocrine therapy sensitive population.
So the question is, again, if you're primarily refractory, think about the genomics of what that is, because I know you love to think about genomics, Joyce. So the thing is that, these are probably people who are FGF mutated from the beginning or p53 mutated from the beginning. Nothing we give them is going to work, but everybody else, but so why do you think then the patient who's sensitive to an AI up front and becomes resistant, why? Why do they become resistant? ESR mutation? What, 30% ESR mutation? We don't know the rest of it, but say 30% ESR mutation, and then they'll respond to fulvestrant, and then you're boosting whatever response you get. I view these agents as boosters, right? Are they really resistance overcomers, or are they boosters of the existing hormone response you're going to get? So when we talk about this being hormone refractory, are they truly hormone refractory to all hormones in Paloma-3 or not? I'm trying to get a sense. You know what I'm trying to say here?
Yeah, I don't think that they were all refractory, but I think the progression-free survival in the control arm Paloma-3 was shorter than the other second-line studies. So I think it was probably a slightly more refractory population than the other second-line studies. But we honestly, as you say, we don't honestly know at this point.
We don't know why they're resistant, because they clearly respond to another hormone therapy, right? They respond to
so I think, your ER is still a very good target in these cancers. I think versus if you look at the mTOR inhibitors and now the PI3 kinase inhibitors, they appear to be more effective in the resistant population compared to the sensitive population, which I think makes sense because I think those pathways become more important as the cancers become resistant.
So you think that's going to give us a way to kind of figure that out? So in other words, when we try to decide, because the decision point, I don't know if we're going to talk about, the decision point is going to be, PI3 kinase inhibitor, obviously with a mutation, mTOR inhibitor, or CDK4 inhibitor, right? In someone who's second or third line. So which do you use?
That's a really, really interesting question. I just wanted to make one,
go ahead, I'm sorry.
one comment about the fulvestrant after progression on CDK4/6. We just haven't really had any data to look at, but in the SOLAR-1 trial that was updated at San Antonio, of course, the SOLAR-1 is for a group of wild-type PIK3CA or mutant PIK3CA patients who had already progressed on an aromatase inhibitor randomized to fulvestrant, placebo versus fulvestrant plus alpelisib, the alpha-specific targeted inhibitor of PIK3CA mutation. And there were just 6%, small numbers, of
10
patients.
per arm.
10 per arm?
That's it. That was 6%. It's 10 per arm.
In terms okay. Well,
Just as
the
a math
the fulvestrant arm after CDK, it came down very, very steeply, and there was a very small tail on that curve. It was interesting to see that, but we certainly need more data.
No, but
on
there
that.
was benefit to the alpelisib in the people who were CDK4.
Oh, clearly.
That had it, but it was only 10
Clearly.
patients per arm. What can you make
Clearly,
of that? That's the
yes,
thing.
but the curves we saw that those
They
curves.
separated, but it was only 10 patients per arm.
Yeah, it was very small, but it was quite reassuring,